Good morning. I'm James Wolfe, and I'm making this camcast on cardiovascular disease to prepare you for the Bekaraljis simulation you'll be doing in IH 880. Some of you may not know, but I am, as well as a professor in the Department of International Health, a practicing emergency medicine doc. And I'm looking forward to the simulation because it's one of the few times when my two avocations, public health and emergency medicine, intersect. So in this camcast, I'm going to try to cover some of the fundamental concepts, both public health and medical, behind the development of cardiovascular disease. Why should we care about cardiovascular disease? We have malaria and HIV/AIDS and diarrhea and acute respiratory infection and TB, and those are the real problems in the developing world, right? Well, actually, no. CVD is now the leading cause of death in developing countries as well as developed countries. Here's a list of the top 10 causes of death. The left side of the slide, in yellow, shows the causes in the most developed countries. And on the right side, in blue, the least developed countries, with orange in the middle representing middle-income countries. And what may be surprising to you is that coronary heart disease, or CHD, is now top of the list for both the most and the least developed countries, with stroke and CVD in 5th position in the least developed countries and moving up rapidly. From this side, we see that it is the poorest countries where most of the population lives that are most affected and account for 80% of the burden of chronic disease. In the graph, the blue bars represent communicable disease and the orange bars non-communicable disease, and the light green bars, injuries. In fact, as we see in this graph, even in the low-income countries, chronic disease has now overtaken communicable disease as the leading cause of death. This table shows the 4 stages of epidemiological transition. The first stage, or pestilence and famine, is dominated by malnutrition and infectious disease. And you can see that the life expectancy is very low and deaths due to cardiovascular disease fairly low. In the second stage, receding pandemics, that stage is characterized by improved nutrition and public health that leads to increases in chronic diseases such as hypertension. And the life expectancy, of course, is now higher. And the countries that are in this situation now are countries in South Asia and Southeast Asia, in the Pacific, and parts of Latin America and the Caribbean. In the third stage of degenerative human-created diseases, there's a tendency on a population basis to increased fat and caloric intake and widespread tobacco use. And this leads to increased deaths from chronic disease and mortality from infections and malnutrition become less important, and chronic diseases, especially CVD, more important. And in the final stage of delayed degenerative disease, cardiovascular disease and cancer are the leading causes of disability and death. But prevention and treatment delay the onset or progression of these diseases and may even prevent death. So let's talk a little bit about cardiovascular disease. Arteriosclerotic cardiovascular disease involves the blood supply to the heart, the central nervous system, and the extremities. Basically, the arteries get narrowed by inflammatory plaques in the arterial intima. These plaques build up inside the wall of the artery, causing narrowing of the arterial lumina. The narrowing increases resistance to blood flow through the arteries. And when this occurs in the body responds by increasing the blood pressure, a condition known as hypertension. When the narrowing occurs in the coronary arteries, there comes a point in time when the blood supply to the heart muscle is inadequate to supply the oxygen and nutrient requirements of the heart muscle, and the heart begins to hurt. And when the heart increases its metabolic demand, which it does through exercise, the narrowed coronary arteries cannot supply enough blood to the heart muscle to meet the oxygen demand, and chest pain occurs. This chest pain that occurs when the heart doesn't get enough oxygen through the coronary arteries is called angina, and it is, of course, a sign of coronary artery disease. When the artery is completely blocked and cannot supply any blood carrying oxygen to the heart muscle, the muscle fed by that artery dies. And when the heart muscle dies, we call this an acute myocardial infarction. It usually happens suddenly when a clot forms in the narrowed artery and completely blocks the blood flow. There are some biochemical markers, which we call cardiac enzymes, that leak into the blood when the heart muscle dies and allow us to measure and confirm that an acute myocardial infarction has occurred. Ischemic stroke is caused by a similar process. There's a narrowing of the cerebral arteries, eventually blocking the flow of blood to a region of the brain, and that region of the brain, supplied by the blocked vessel, then ceases to function, and like the cardiac muscle in an acute myocardial infarction, it dies and results in a specific neurologic defect corresponding to the part of the brain that is no longer functioning. We've talked a little bit about hypertension, which occurs mainly through narrowing of the arteries and increased resistance to blood flow through the body, and congestive heart failure, which is the end stage of many heart diseases caused by ischemic heart disease and high blood pressure. Rheumatic heart disease, of course, is not an ischemic heart disease, but rather caused by a strep infection that affects the function of the heart valves, and over time this causes heart problems, including congestive heart failure. So ischemic heart disease, which is a broad term that encompasses angina and acute myocardial infarction and congestive heart failure, causes about 7.3 million deaths a year and accounts for 58 million dailies lost annually. Angina has a 2% annual mortality rate, and acute myocardial infarction has a 33% 30-day mortality rate, with half of the deaths caused by acute myocardial infarction occurring before the arrival to hospital. And this is one of the major reasons why so much effort, especially in developed countries, has been put into pre-hospital care and bystander CPR, because most of these deaths occur from an arrhythmia. They occur at the time of the MI, and there is, in general, no opportunity to intervene at that point, except with resources available in the community. Most recently, the semi-automatic or automatic defibrillator is increasingly available to people who have arrhythmias from acute AMI in the community. Congestive heart failure, as we've said, is the end stage of many heart diseases. And high blood pressure increases the risk of congestive heart failure by 2 in men and by 3 in women. Actually, the prognosis for congestive heart failure is worse than the prognosis for AIDS or malignancy, and mortality rates are as high as 40%, and 5-year mortality is somewhere between 26 and 75%. The prevalence, of course, of congestive heart failure rises with age. One of the major risk factors for stroke is atrial fibrillation. Atrial fibrillation occurs with increasing frequency as people age. Atrial fibrillation is a heart rhythm disturbance which results in an atrium that does not contract properly. Instead of squeezing down and forcing the blood out of the heart, the atria quivers and the blood is not forcefully ejected from the atrium into the ventricle, which is the major chamber responsible for pumping blood forcefully to the body and to the lung. The sluggish flow of blood through the atrium that isn't contracting predisposes to forming clots because the blood eddies in the corners of the atrium and can easily clot. Clots forming in the heart, in the atria, then travel through to the ventricle and then can be pumped out into the arterial system, ending up either in the lung, where they cause a pulmonary embolus by blocking the pulmonary arteries supplying blood to the lung, or to the brain, where they cause a thromboembolic stroke. Treatment for atrial fibrillation involves anticoagulation to prevent clot formation. 50% of thromboembolic stroke is from atrial fibrillation, which has an annual risk of stroke of about 3 to 5%. So let's talk a little bit about the double burden of disease in many developing countries who are currently experiencing the epidemiologic transition. These countries are challenged with responding to both the burden of childhood infectious disease and the rising incidence of non-communicable disease. And some of the reasons for the increasing prevalence of non-communicable disease are increased use of tobacco products, a more Western diet which contains increased amounts of salt and animal fat, a tendency to not to exercise, and consequently both the increased animal fat and the lack of exercise predisposes to an increased incidence of obesity in the population, increased hypertension, increased alcohol use, and diabetes. So the CVD epidemic, as we've said, is becoming a global problem. There's a demographic shift of increasing life expectancy, of changes in nutrition to westernized diets, of increased tendency for physical inactivity, leading to high blood pressure, obesity, diabetes, and high cholesterol. And there is, sadly, increased tobacco trade and rates of smoking that are increasing worldwide. So what can we do about this? Well, we can focus on some of the causes, tobacco use, treating high blood pressure, treating diabetes and preventing diabetes, uh, dealing with lipid abnormalities, with the obesity epidemic, with physical inactivity, and being aware that there are people who are at risk for genetic factors like a family history of heart disease. So when it comes to risk factors, we have to focus on those factors that we can modify. We can't do much about the circle on the left, our age, our sex, our family history, or our genes, but we can certainly modify our behaviors like smoking, high blood pressure by reducing our salt intake and exercising regularly. And we can focus on secondary prevention, that's the circle on the far right, using a number of different drugs to prevent disease progression once it has developed. Just want to say a couple of words about obesity. In the past 20 years, the rates of obesity have tripled in the developing world. And we've mentioned some of the reasons for this: the adoption of Western lifestyle, the decreased physical activity, and the overconsumption of cheap, energy-dense foods. And finally, this is our last slide. Diabetes is a major risk factor for CVD. Diabetes is rare in countries where traditional lifestyles are preserved. By contrast, in those countries that have undergone this process of westernization and urbanization, diabetes risk is greater, and prevalence in these populations is rising and is now somewhere between 14 and 20%. In fact, there were 366 million cases of diabetes projected for 2030, and most of these will occur in the developing world. So that's really the end of our primer on cardiovascular disease, which, as we've said, is the leading cause of death in both the developed and the developing world. And hopefully some of these concepts and this information will be interesting and useful to you when you engage in the Bekaraljis simulation. And I know I'm looking forward to that, and I hope to see you there and to work with you during the simulation. So until then, take care, be well, and look to see you soon.